My talk will be on preoperative considerations and special situations. Dr. Harold Ridley, who implanted the first intraocular lens, lived to see cataract surgery evolve into a true refractive procedure. Today, I will be talking how to maximize our outcomes and include brief discussions of specific types of challenging eyes. Whatever eye it is, either it's a long eye, short eye or a post-refractive eye, but the most important thing is to do a meticulous preoperative workup. The three important C's to look into is corneal health, careful biometry and the choice of formula. This is one example where a dry eye can make your biometry measurements very inaccurate. When we look into this biometry, we can see the right eye has only a 0.5 diopters of astigmatism, whereas the left eye it shows 2.87, and this reflects in the IOL power where there is around 2.5 diopters of difference between this eye. So on examination, the patient tend to have severe dry eyes. The patient was put on plenty of lubricants, and once the corneal surface is tuned up, we get more accurate results. Here, after treating the dry eyes, the patient had 15 diopter of lens as equal to the other eye. Another thing is anterior segment examination has to be done thoroughly. Look into the cornea and look for any gutting. Here in our institution, we do a specular microscopy for all our patients, and if at all there is any Fuchs underlying dystrophy, we can take an extra care so that we are not going to damage the corneal endothelium further. And we also assure the patient that they may require an endothelial keratoplasty later. So if anything that would show up later in the post-op results, both patient and the surgeons are aware of it. This is another example where the importance of OCT comes into play. This is a patient who had a nucleosclerotic cataract both eyes and with a thin ERM. The OCT showed with the ERM with a vitreomacular traction, and the patient has been planned a combined surgery, and post-operatively he did very well. This is another case example showing biometry of a patient planned for the right eye cataract surgery. The IOL power was same in both eyes, but a closer look revealed that the patient had a flat K in one eye. On further probing, the patient said that there is a history of LASIK done 30 years back in the right eye. So the mode and the formula is then changed in the biometer, and the IOL power was calculated. So all these case scenarios just tells us that we should look into the validation guidelines. So when there is an asymmetry between the eyes with regard to axial length, K reading and the IOL power, we should always recheck it again, and if needed, reconfirm it with another device. And now coming to the IOL calculation formula, these formulas fall into two major categories. One is a theoretical formula which was derived from the principles of geometric optics. Another is the regression, which is generated by averaging a large number of post-operative results. Depending upon when they evolve, we have 5 generations of formula. But the logical approach of classifying the formulas is based upon what data they take and what is their method of calculation. The first is a historical, which is obsolete. The second is regression, and third is vergence based upon this geometric optics. And depending upon what all the variables they take into calculation, we have 2 variable, 3, 5 and 7. It doesn't mean that once we take more variable, we are going to get an accurate outcome, but we have to take the right variable to get the correct outcome. The fourth one is the artificial intelligence, which is the example is the Hill RBF, which is purely data driven. The last is the evolving ray tracing method. Then the question comes, how are the new formula different from each other? The effective lens position. The important goal of all these formula is to continuously improve our ability to predict the effective lens position. This is the distance between the anterior corneal vertex and the implant's optical center. We require certain measurements like axial length in keratometry to predict the effective lens position. So all these formula differ in how accurately they predict the effective lens position. Most surgeons are aware that the recent formula are capable of producing more accurate results, but many surgeons continue to use the older formulas. To understand how much difference switching to an advanced formula, it is important to look at our outcomes. This is a database of Warren Hills where he analyzed, he has a 250,000 post-operative surgical outcomes of all the surgeons. When he analyzed between the old versus new formula after removing all the outliers, he could see that only 78% of the surgeons could achieve within a 0.5 diopters of a target refraction, and only 1% of the surgeons achieved this 0.5 diopters. But with the newer formula and newer biometers, 90% of the surgeons could achieve the same. So what was achieved by only 1 to 2%, now 90% of the surgeons could achieve a 0.5 diopters of the target refraction. So we must move to the newer formulas. This is our own results, where with the third generation formula we could achieve only around 80% of the eyes within the 0.5 diopters. But switching to the Barrett universal formula, not even in normal eyes, even in short eyes, we were able to achieve a 90% accuracy of within 0.5 diopters. So our standards are pretty much the Barrett universal 2 formula. Should we plug our numbers into multiple formulas and compare the results? For normal eyes, this is purely optional. Surgeons who are using the newer generation formulas need not do this. But in problem eyes, challenging eyes like extremes of axial length and post-LASIK, it is better. We can plug our details into multiple formulas. But while choosing the formula, we should choose what is well suited for that eye. If you are going to deal with the extreme myopes, we should take into account of the Barrett universal 2 or Hill RBF or a Bangkok modification of the third generation formula. But if you are not going to choose the formula which is not going to well suited for that type of eye, it is going to just add a mathematical noise. Will we have ever one formula that works for every eye? First, we should understand this dimensional matrix of the human eye. 76% of our population have normal axial length with normal anterior segment, 9% are hypermetropes. Out of this 9%, 7% of the people have normal anterior segment, and out of the 15% who are myopes, 13.5% have a normal anterior segment. But our third generation formulas assume that long eyes always have steep case and a larger ACD. This is where the error comes. And as has already been talked about, the newer formulas perform better. Barrett's universal 2 formula takes into account of the 5 variables which has been already alluded to. Another newer generation formula is the Hill RBF. This is a purely data driven. The first version of the Hill RBF formula was optimized for IOL powers between +6 diopters to +30. The beta version, which is the extended version, extend the IOL power as far as -5 diopters. This is an ongoing project. It means that more the data is entered, the greater the depth of accuracy. When we look into the first picture, where the data was around 3,500 eyes, when we put into the data, this red color circle mark, it tells that our reading is out of bounds. Out of bounds meaning the Hill RBF database does not have adequate data to give an accurate result. And when it has moved, the beta version which had more of the eyes, it is around 12,500 eyes, now the previously out of bounds now turns into inbounds. Inbound calculation means that it has enough data to tell that the prediction accuracy of the IOL power is accurate. What is the best way to deal with the very short and long eyes? The problem with short eyes, even the best formula can run into trouble in this short eyes. There are many reasons. One is like even a small error in the measurement is going to give a larger refractive surprise. Another, we don't know whether the short anterior segment is an anatomical feature or it is because of the increased lens thickness because of aging or cataract. All this puts into a trouble of difficulty in predicting the effective lens position. And this larger powered IOLs, even if the effective lens position moves little bit anteriorly, it is going to give a larger myopic surprise in the postoperative period. This is one study which have analyzed all the 7 formulas ranging from the newer formulas and also the Hoffer-Q Holiday 1, 2, and it is showed that there is no statistically significant difference in the mean absolute error predicted by all the 7 formulas in the short eyes. Another thing is like we have a high powered IOL, so what is the choice, whether we are going to go with a customized IOL or the piggyback IOL. The problem with customized IOL, if we have any risk of biometry error, then we are going to fall short back. The piggyback IOL option is like we can implant the maximum power available and then postoperatively we do the refraction and then calculate the power of the piggyback IOL. The challenge in the long eyes is extremely different. Here the problem is how to measure accurately the axial length. In case of cephaloma, in an immersion A-scan, we are not going to get a distinct retinal spike. And the immersion biometry is going to measure the anatomical axial length rather than the refractive axial length. The optical biometry assumes that an average index of refraction, and so it erroneously calculates the axial length to be longer. So when you are going to use optical biometer with a third generation formula, we have to use the Bangkok modification, or else we can go ahead with the Barrett universal 2 formula or the Hill RBF if you are going to get inbounds calculation. Coming to the post-refractive surgery eyes, first we understand what is the problem and what is the accurate way. The problem all threefold. One is the keratometric index error, second is the instrument error or the radius error, and third is the formula error which extrapolates the effective lens position. The keratometric index error is that the keratometers measures the anterior corneal radius of curvature and it uses the keratometric index of refraction which is 1.3375 and it calculates the total power of the cornea using this formula P is equal to n minus 1 by R, and it assumes that the anterior to the posterior corneal curvature is constant which is 82%, but this percentage alters after a refractive surgery, either it be LASIK or the RK. The second is the instrument error. Most of our keratometers and topographers are blind to the exact center of the cornea. They measure the paracentral area and extrapolates and gives us the central corneal power. This instrument error or the radius error comes into play when the optical zone is small or decentered. All this keratometry error problems, it leads to underestimation of a power after post-LASIK and a post-operatively a hyperopic surprise. Coming to the formula problem, the third generation formula calculates the effective lens position based upon the corneal curvature. Since here after a LASIK, myopic LASIK, we get a flat K, we are going to err in the effective lens position calculation. So one solution was suggested by Arambari, where he suggested that to use the pre-LASIK K for calculating the effective lens position and the post-LASIK K in the Virgin's formula for calculating the IOL power. So the solutions for estimating the corneal power, one is the total keratometry, and you can use a topographer like Pentacam and the GLED. The total keratometry has already been talked about. It gives the total corneal power by using the telecentric 3-zone keratometry and the Swepso OCT. The Pentacam, the Holiday 2 report, which gives the equivalent keratometry, and this 4.5 mm at the region of 4.5 mm, which can be used in the Holiday 2 consultant program, or we can use this Pentacam 4 mm zone value of the total corneal power and use it in the ASARS calculator. The next is the Galilee's 4 mm total corneal power, which is calculated using ray tracing, that it measures the anterior corneal surface, posterior corneal surface, and also the pachymetry. It takes into account of the corneal thickness, and it uses the actual index of refraction of the interface, and it gives the total corneal power, which can be used in the ASARS calculator. The formula error, what formula to use? We have multiple formulas which has been suggested depending upon the availability of pre-op K, surgical induced change in refraction, and it is very time consuming to understand and apply all this in a day-to-day practice. This is made simplified by using the ASARS calculator. The previous version of the ASARS calculator uses, there are 3 groups of formula. One that uses the change in the manifest refraction and the pre-LASIK K, another second group that uses only the change in manifest refraction, and the third group which doesn't use prior data. When you look into this article, the clinical history, which was once considered gold standard, but it produced the accuracy of less than 60% of eyes within 0.5 diopters. So the initial, that clinical history, which is the pre-LASIK K and the change in manifest of refraction, the first group of formulas were removed from the ASARS calculator, and now we have only these 2. The one with the change in the manifest refraction and one that uses no prior corneal data. And this is available in the APS-ARS website, and we have for myopic LASIK, where you can enter the pre-LASIK data, the refraction reading after 6 weeks of the LASIK, topographic reading and the biometry reading, and we are going to get the IOL power. Similarly, we have for hyperopic LASIK. And of much importance is this, the Barrett True K formula, which performs better when compared to the other formulas. The mathematical formula behind this method has never been published, and we assume that it calculates the modified K and provides the double K solution, which is available in the APS-ARS website. And this is also available in the IOL Master 700. And once you change the mode to LASIK, the particular type of LBC mode, whether it's hyperopic, myopic or RK, we can get the IOL power. This is our own experience with the ASARS calculator and the Barrett True K formula, where we found that Barrett True K formula outperforms even the ASARS calculator, and it gives around 88% of the accuracy within 0.5 diopters. And it has been shown that it performs even better than the Hexel formula. Radial keratotomy. The challenge is difficulty in determining the true corneal power due to the irregularities induced by RK incision, And even intraop aberrometry, because of the change in the corneal incisions during cataract phacoemulsification, it is also less accurate. So the key concept is measure close to the center, and we can use this ASRS calculator for prior RK. And the thing we have to consider is post-operatively these patients will have transient hyperopia, and it takes around 2 to 3 months to settle back. So wait until it returns to the pre-op K value. This is one case example of a patient who underwent RK, and for the first time we calculated the values, the axis length and K using the lens star, and we fed into the ASRS calculator, and the average IOL power was around 24.65, and so we implanted 24.5 diopters. As you see here, the right eye had immediate post-op a hyperopic error of +2 diopters, and when the patient came 2 years later for the left eye, the IOL calculation was done using the ASRS calculator, and the patient was doing well. Even the hyperopic error which was there, it subsides. So to conclude, always validate your measurement. It acts as a quality check. Don't remove yourself from the process, and spend extra time counseling the patient with short eyes and previous refractive surgery, and always stay informed about the latest development. Thank you.